Good morning, everyone. Just to clarify, my financial disclosures are in my part of the talk, but Andy has no financial disclosures. And I'm going to go through his slides, so bear with me. So again, Andy has nothing to disclose. So this is information for the state of Utah. We have around 50,000 births per year. We are a two-screen state. The first newborn screen is collected between 24 to 48 hours of life. The second newborn screen is anywhere between 7 to 28 days of life. The kit for newborn screen costs $112. There's no funds or subsidies for that, so the newborn screen program bears all the cost, and the fee includes almost everything, and it screens for 40 disorders. This is a list of the disorders that are screened by the Utah Newborn Screen. Why is it important to do a second newborn screen? For many reasons, and the examples that we're going to focus on today include cystic fibrosis and congenital hypothyroidism. The reasons include financial reasons, saturation of resources, and stress and anxiety for patients and families. So this slide shows us the numbers for Utah, and as you can see, the number of children that are positive for the first newborn screen are reduced significantly by the second newborn screen. If we were to do only one screen, that means we would be taking all roughly 1,000 infants to the next step of testing, which, as you can imagine, very expensive. By the time we do the DNA, we cut the numbers significantly further down. As you can see in this slide, it shows you how much money we save every year by doing the second screen. This number does not include further testing, like doing sweat chloride tests when they come to the clinic. Not to mention, we spare 1,000 families the stress of being told you have a positive newborn screen, you need further evaluation. I'm going to skip this slide and the next one because I have a similar slide in my presentation that I can go over in details. In 2017, the newborn screen team led a QI project that they examined the newborn process and tried to, for cystic fibrosis, and tried to identify the areas of limitations or the bottlenecks. And we found out that DNA testing was the main delay area. It used to be outsourced to a lab in California, and the time to completion of the DNA testing used to be around 35 days. The project was to insource the genetic testing component to the Department of Health here in Utah. And by doing so, they were able to reduce the age from 35 days to 23 days. I'll talk later about the implications of that QI project. So now I'll go to my actual part of the presentation. So in the next 15 minutes, I'll share with you why a timely newborn screen for cystic fibrosis is vital for patients with cystic fibrosis. I received funding as listed. None of it is really related to today's topic. It all started in the 1980s. Back then, an infant born with cystic fibrosis was expected to live less than 28 years. Centers in certain states like Wisconsin started doing newborn screen for cystic fibrosis using IRT. IRT stands for immunoreactive trypsinogen. It's a pancreatic enzyme precursor that it was found to be elevated in infants with cystic fibrosis. Based on their findings, the Cystic Fibrosis Foundation reached out to the CDC, and in 1997, the CDC recommended that states do newborn screen for cystic fibrosis on research basis with an informed consent. What they found is that earlier diagnosis and earlier interventions led to improved nutrition and growth. Screened patients compared to non-screened patients had better weight for age percentile and height for age percentile. Non-screened patients, their growth deficits were irreversible in many cases. They also found significant differences in fat-soluble vitamin levels, cognitive function, survival, and hospitalization rate. And based on that, in 2003, the CDC recommended that states consider newborn screen for cystic fibrosis. What we saw after that is many changes. In the graph on the top, we see here that every year, it shows you the number of new diagnoses for cystic fibrosis. The yellow line is what percentage of them was diagnosed through the newborn screen. As you can see, after 2003, as states started adopting newborn screen, the percentage diagnosed through newborn screen increased significantly. The lower two slides show us that nutritional outcomes for children between 0 to 24 months and from 2 to 19 years all improved significantly after introduction of cystic fibrosis newborn screen. We're looking at weight for length, weight, length, and BMI and height and weight for older children. In 2009, and after strong advocacy from Dr. Chatfield, Utah started newborn screen for cystic fibrosis. Locally, we saw similar results as we've seen nationally. I'm going to have many slides like this, so I'm going to take a minute to explain what you're looking at. These are the slides we receive in our center-specific report from the CF Foundation. We receive that every year, and the slides I'll show today are from our report from 2016. The graph, the upper graph shows all the centers in the country. Every blue bar is a CF center. The red bar is our center, and the green bar is the national average. The lower graph shows the trend for the last 10 years. The red line is our center, the green line is the national average, and the blue line is the top 10 centers for this category. This particular slide is for median WHO weight for length percentile. This is the main nutritional outcome for kids between 0 to 24 months, and it's tracked by the US News and World Report. And as you can see, since we introduced newborn screen in 2009, we have had quite a bit of improvement. And this slide shows our median BMI percentile for patients from 2 to 19. That's also the main nutritional outcome for this age group, also tracked by the US News and World Report. And we see the same effect. Since introduction of newborn screen in 2009, we see quite a bit of improvement. And by 2010, all 50 states were performing newborn screen for cystic fibrosis. Not all states screen the same way. We have one screen states, which means they do one IRT level, followed by DNA testing. And then we have two screen states. Two screen states do it in one of two ways. Some of them do IRT level, followed by a second IRT level, and the rest do it IRT level, followed by a second IRT level, followed by DNA testing. And that's what we do in Utah. This is our newborn screen algorithm for cystic fibrosis in Utah. It works really well for us for the reason I mentioned earlier. As you can see here, we perform the first IRT. If the level is above the cutoff, we move to the second IRT. If the level is above the cutoff, we move to DNA testing. And based on the results, the number of mutations, that dictates the clinical care needed. I also want to emphasize that the clinical portion of the newborn screen, once the new DNA testing is completed, is very efficient. We get the patients in clinic in 24 to 48 hours. This slide was shared at the most recent Cystic Fibrosis Conference. It's comparing all states to time to diagnosis. The red bars are the one screen states. The green bars are the two screen states. Utah ranked third to last, or as someone told me, tied in last place. Regardless which one, I know we can do better than this. The accuracy of information in this slide is questionable, but I think the better question to ask is this affecting our outcomes? This slide is for median WHO length percentile for patients from 0 to 24 months. As you can see, Our infants and toddlers are 23.7. We're below the national average, significantly below the top 10 centers, and we're below the recommended 50th percentile. What this means is that our infants and toddlers with cystic fibrosis are stunted compared to the rest of the country. To go back to the same newborn screen quality improvement project that the newborn screen team led in December of 2016, I mentioned we were able to decrease the age of diagnosis anywhere from 31 to 35 days down to 23 days. But keep in mind, this is time to finishing the DNA testing. Add 1 to 2 days for this for time to completion or for time to be in clinic. A good goal for us is to finish by 20 days, to have them in clinic by 20 days. And I think the two questions that come to mind is, why is it important? Why does every day count? And does this make a difference to go from 31 or 35 days to 23 days? So what we know about nutrition in the first year of life is that weight gain velocity is the highest in the first 2 months of life. This is for all children, but it also applies for patients with cystic fibrosis. What we also know is that 20% of infants with cystic fibrosis fail to reach their birth weight Z-score by the first year of life. And if we look at the ones who were diagnosed later, the number goes up to 31%. And to go back to the second question, does it matter? Did decrease the time to diagnosis make a difference in our outcomes? Our preliminary results suggest that it does. This slide shows you comparison between our CDC weight for length percentile between 2016 and 2017. The goal, according to CDC growth charts, would be the 50th percentile. And after this QI project, we seem to be closer to achieving that goal than before. Why do we focus so much on nutrition? We have established that diagnosing them earlier can improve their nutrition and growth. But why is that important? As you can see in these graphs that look at survival over years for patients broken down by weight percentile on the left and height percentile on the right. You can see that patients with better nutrition have better survival. These graphs are from the Cystic Fibrosis Foundation patient registry, and they show us the positive correlation between nutrition and lung function. Nutrition is measured by BMI percentile for children and BMI for adults, and lung function is measured by FEV1. That stands for forced exhaled volume in 1 second. And as you can see, as nutrition goes up, lung function goes up, and it's consistent in pediatrics and in adults. This graph shows us how patients who are nutritionally compromised with a BMI less than the 10th percentile compare to patients who are not nutritionally compromised with BMI above the 10th percentile. The first graph compares or looks at lung disease detected by a chest X-ray score over time. We can see here that the green line for the compromised patients, they have more lung disease over time compared to the ones with better nutrition. In the second graph, we look at lung function measured by FEV1 over time. Same thing. For the green line, the patients with the compromised nutrition, we can see faster decline in lung function compared to patients without nutritional compromise. So to summarize, earlier diagnosis and earlier interventions leads to improved nutrition and better growth, which are associated with improved pulmonary and survival outcomes. And this is how we go from expecting infants born today with cystic fibrosis from living only 1 year in 1938 to expecting them to live 47 years in 2017. 47 is a great number. We have achieved a lot, but we don't think it's good enough. Because would any of you be happy if you were told you're going to live only 47 years? Some people exceeded the 47 years. As we acknowledge our limitations, I just wanted also to acknowledge our accomplishments. This slide is for FEV1, the main pulmonary outcome for patients between 6 and 17, also an outcome that is tracked by the US News and World Report. And as you can see, in 2016, our center ranked 6th in the country at 100.2%. 100% would be a normal FEV1, normal lung function. And I want to acknowledge and thank everyone in the cystic fibrosis team. As you can see, it does take a village. And I'll pass the microphone to Dr. Murray.
My goal is to switch gears a little bit. So CF is a relatively new screening protocol, and my goal is to shift back to one that's been present since very early on, and that's congenital hypothyroidism. Nothing to disclose. So just a little bit of background. Thyroid screening in the newborn screening started in the 1970s, late 60s in the US. Screening for congenital hypothyroidism is indicated because hypothyroidism is hard to diagnose. The symptoms are relatively nonspecific. The majority of the cases are sporadic, so you don't have an indication to assess the patients. If you're going to start a newborn screening program, you have to have an effective treatment, and the treatment has to make a difference in the lives of the patients. And this is true for congenital hypothyroidism. There's an effective and easy and inexpensive treatment, and that's giving levothyroxine to the patient. And the treatment makes a huge difference. So prior to newborn screening, most kids diagnosed with who had congenital hypothyroidism were reported to have IQs in the 70s when they were grown. This is the cretin, where the name cretinism comes from. I have seen one case of cretinism in all of my practice. I forgot to ask Carol if she's seen any, and Rob if they've seen any. I also met in the last 5 years a woman. I was seeing her 18-year-old daughter was going off to college, and she was diagnosed in one of the very first states that started newborn screening. So I think the difference in lives to these families and kids is extraordinary. And I think that supports that newborn screening is a success story. Newborn screening has also led to increased recognition. So prior to newborn screening, the incidence was thought to be about 1 in 4,000, depending on who you read now and whether you're looking at European or American or very different state literature. The incidence now is being reported as somewhere between 1,800 and 3,000. The reason for the increased incidence is not known. I mean, I think some of it could be blamed on premature births and difficulties in assessing low birth weight babies and how they factor into this. But I don't think that's the whole story based on the literature. And we still have some challenges. Even though I think this is a successful story, we still have some challenges remaining. Some of the controversies, if you look through the literature, is what is the best testing paradigm? Is it a TSH versus a T4 as the primary screen? And should you be doing 1 screen or 2 screens? There's also some controversy over what is the normal range, and that can apply to whether you're doing 1 screen or 2 screen. When you start a screening program, your goal is to pick up kids that are likely to have it, so you risk over-treatment at the cost of trying to get an early diagnosis. So you have to balance both of those things out. As Fadi said, the newborn screening program in the state of Utah is funded by the cost of the kits. So I think we have a fiscal responsibility to control the costs that the state has to pay for this, but we have to and we have to do that, but we also have to think about the cost to families. So no matter how many times you as a pediatrician will tell a family, don't go to the internet and look this up, the families will go to the internet and look this up. And even though the state of newborns of congenital hypothyroidism is very different in most of our lives, the medical textbooks and the internet still talk about cretinism. So when you have a brand new beautiful baby and you go look on the internet and they tell you this baby is going to be severely developmentally delayed with an IQ of about 70, you can imagine how devastating that can be. And that's a lot of stress for the family, not to mention the additional blood tests and things like that that have to be done. Another controversy is whether we should have different normal ranges for the first and the second screens. Based on physiologic patterns of thyroid function in the newborn. And what is the impact or outcome for those who have mild elevations? So let's say they're above what we call the normal range in the lab, but they don't meet our screening normal range. What impact, if any, does that have, and how should we treat those kids? And then the NICU is a whole nother kettle of fish with its own set of controversies. So switching to talk a little bit about Utah. So Utah, the incidence is, based on our current data, is 1 in 2,800 births. Your handout says 2,300. That was my typo. I apologize. The TSH is a primary screen. In 2009, we switched from a primary T4 screen to using TSH as the primary screen, and this was to help control costs. There were a lot more false positives with the T4 screen, and so by switching to TSH, we minimized the number of false positives or people that had to be called back and retested, but we didn't lose any ability to diagnose the kids based on our review of the data. So currently, if the TSH is flagged as abnormal, the lab goes back, pulls the filter paper blot that they have, pulls another plug from that, does another assay confirming the TSH and also measuring a total T4 before releasing the result. This takes in the lab, this takes about another day to day and a half probably to get the report out after that. We are, as Fadi said, a 2-screen state. Current mandate from the state is that the second newborn screen be completed between 7 and 28 days. National benchmarks for initiating treatment of an infant with congenital hypothyroidism is the treatment should be started between 14 to 21 days. So our second screen is already a little bit late to meet that criteria. The variation between 14 and 21 days probably relates partly to whether you're a one-screen state. 14 days may be appropriate. If you're a 2-screen state, you probably can't make all that. And then there was a recent abstract that suggested we are missing cases in the state of Utah, and that abstract suggested that we missed about half of the newborn hypothyroidism, congenital hypothyroidism in the state. So given that there were still lots of issues to be looked at, we undertook the review of the data from the newborn screening program. And Andy and Kim and David Jones are not here, but I do want to say that they've done a tremendous amount of work and they're great partners to work with. So David Jones is the statistician informatics person there now, and he pulled most of this data and looked at it, helped us look at it. So we looked at the data between 2010 and 2016. During that time, over 350,000, almost 360,000 infants were screened. We had 130 cases of congenital hypothyroidism diagnosed. 98 of those cases were diagnosed on the first screen. 25 of those cases were diagnosed on the second screen. I think this is an argument that the second screen is important. 7 of the cases that were identified were excluded, and that was because we had incomplete data. Maybe they were born in a different state or whatever. In 2016, the average age at diagnosis reported to the newborn screening program was 24 days. So if our goal is under 21 days, we're not at this point meeting that. If we look at our population at the endocrinology division at the university here, our average time to diagnosis is 12 days. We have to track this for the US News and World Report, and it counts for big points there. So it's something that we want to track. I think part of this may reflect the fact that a lot of the kids that we see are the kids that have what are called critical lab values. They get flagged early and referred faster. So the second screen kids may be the ones that are skewing the Department of Health screen towards a later age at diagnosis. The current screening protocol, as I said, is a primary TSH screen. Anything greater than 200 is critical. I think that's a fairly arbitrary value that was pulled because it's the top of their assay. And we actually probably haven't looked at that in a few years, and it may be time to look at that again. This triggers an immediate pulling of the sample again, repeating a measurement of a T4 and reporting both of those out emergently. So any pediatrician here who's had a case has probably gotten that phone call. Between 40 and 200 is flagged as abnormal and it deserves follow-up. And the usual protocol for the lab is to call the physician of record and ask for the second screen to be submitted. So the follow-up is actually the second screen in those cases. As I said, the T4 is measured in all of these cases, but it does not replace confirmatory labs. So I think any of you who've had a patient like this and have called any of us, get the answer, get the labs done right away. So it's not a final definitive diagnosis test. You still need confirmatory testing in the lab. The state lab measures a total T4, and there are some idiosyncrasies with that test that the IHC lab or primary children's lab does not have because they're measuring a free T4. The same process and criteria apply to both the first and the second screen. Even though we know that the physiology of thyroid in newborns is different changes significantly over the first 2 weeks of life. So right after birth, there's a big surge. And then over the next few weeks to months, the TSH level and the free T4 both come down a little bit. So at the moment, we're applying the same criteria to both samples, and the question is that the best thing to do? And then what we'd like to do is see if we can improve. So one of the things that David and Kim and Andy helped us do was look at the normal distribution of TSH values on the newborn screens. So they pulled the 360-ish screens and looked at the mean day of collection, which was 1.7 days for the first screen, and the mean TSH, which was about 10.6. Pretty big standard deviation there. And a TSH of 40, which we use as our cutoff, is the 98th percentile for the population distribution. On the second screen, the mean day of collection was almost 16 days, so already we're getting out kind of beyond that window for getting a timely return. The mean TSH was 3.8 to 3.9, and the TSH of 10 was the 98th percentile for that population. So the fact that we're applying the same standards to both populations probably needs review and revision. David also, in data I wasn't going to show, also looked at the TSH levels by different days. So the first 5 days, day 1 to 2, 2 to 3, 3 to 4, and 4 to 5. And the TSH mean dropped during that time from about 10 to 11 down to about 5-ish. He also looked at the TSHs on days 12 through about 17, I think, and the mean TSH there was hovering between 3 and 4. So there's quite a bit of change in TSH levels in the first few days, but much less by the second screen. So I think we concluded that the reference range probably needs revision, and you should expect to see some changes coming on that. The other question we had was, is the second screen necessary? Can we just do this on the first screen? So we found that about 20% of our kids were picked up on the second screen, and we looked back to say if we rearrange the reference range on the first screen, would we have picked these kids up? So could we save time and money for the state by consolidating into one screen? So this is these are the results. Do I get the mouse? I guess I don't get the mouse on there. So the green line is our cutoff at 40. The blue turquoise dots below the green line are the results of patients on the first screen who subsequently had an abnormal second screen. So you can see that even if you dropped the reference rate, the normal range down below 40, you would still miss a significant number of those kids. So the second screen is really picking up kids that we're going to have a very hard time identifying and picking up on the first screen. So we would argue that the second screen is indeed important, and the timing of it is also important based on our data of when treatment is started compared to national benchmarks. One of the problems that we looked at with dropping the normal range here is that when you drop that, you start to get false positives. So you're constantly balancing the cost, both emotional and financial, of chasing down the false positives versus missing somebody. If you dropped the the cutoff point here from 40 to 20, you would pick up about half of these cases would be identified on the first screen, half of them would not. But in addition to identifying that half, you would also increase your false positives by about fourfold. And if you dropped it much lower than that, you start going up astronomically. So given that balancing act, we're kind of still hanging in this sort of a target range here at the moment. So based on the program data, the average start of treatment is 24 days overall, and we're missing our deadline target of 21 days. As a two-screen state, I think we have to use 21 instead of 14 because you have to have time to process these samples. So even though the sample might be collected on day one of life, it has to be sent to the lab. It has to be processed by the lab to make sure that the dots on the filter paper are correct. The assay has to be run and the assay has to be confirmed. So it's going to take you a week or so to get that report out. I would like to put in another plug for the newborn screening program, and Andy, since he came here, he has changed their work processes, and the reports are coming out significantly faster. The lab is now running 7 days a week, whereas it used to run 5, and so we're getting much more timely reports, a real significant improvement. But we still are struggling, and again, I think our population gets picked up because it's probably mostly the critical values, the really scary ones that get referred right away. So we can identify these patients and get them in earlier, but we're going to have to do some work to do that. From the data on congenital hypothyroidism, I would argue that we do need to do a second screen. We are picking up kids there that we are missing on the first screen. We're picking up about 20% of our kids on that screen. Exactly why this population is different, we don't know yet. We're digging into that a bit to try to figure it out, but it does appear that those kids do need to be are best identified on the second screen. If we look at reducing the abnormal flag on the first screen to try to increase turnaround and pick up patients earlier, we're going to generate so many false positives that I think doctors will get alarm fatigue and will just generate a huge amount of expense for the program and stress for families that aren't in trouble, that it's a false positive. The T4 that the program does is kind of a holdover from previous years. It really doesn't add a whole lot. It slows down the reporting, but and there's no endocrinologist who accepts that as the final answer. We all want a repeat. in the lab, because there are some idiosyncrasies with this test that other tests can get rid of. So we're actually missing something and delay. We're not missing anything, and we could delay reporting. So we'd like to get rid of the T4 testing and just stick with the TSH as far as the newborn screen goes, to try and increase our turnaround time. So the proposals that we would like to make, and this is what we would like to propose to the pediatricians in the audience, and I know the newborn screening program wants feedback. I think Kim Hart's email address will be here at the end to reach out to her. So TSH will remain the primary screen. We'll discontinue the T4 as it doesn't add anything. It doesn't add a lot of cost to the program, but it doesn't add anything knowledge base, and it delays reporting out. Screen on the first screen, we'll continue with 40 for now as our cutoff, but this we will continue to evaluate over the next few years. But when you get a flag of 40, we're asking that you get the second newborn screen done quickly. So not necessarily waiting until the baby comes in for their 1-month checkup, but calling and having the baby go to the lab and get this second test done, or come in if they're there for a weight check or something, get this test done. Because part of our problem is, in order to try to make it more convenient for the family, we think that's part of what's leading to the delayed testing, is that the baby isn't due in for a few weeks. We'll talk about it when they're here for their well check, whereas we would really like to see this second newborn screen done earlier. 20 to 40 is a borderline value, and we're kind of struggling with what to do with that right now. Dropping the screen to less than 20 is going to pick up about half of our kids, but miss half of our kids and increase our false positives. And then we actually probably need to refine our critical value. That's just a holdover from something. But there will still be a critical value, and at that value, it will be important to get the kid in immediately and probably just go right to confirmatory testing in the lab. Screen number 2, we think the biggest problem there, we think, is the timely collection. And I think this applies to the CF patients also, is that we really, right now the mandate is out to 28 days, and we would really like to see that reduced to a target collection of 7 to 14 days. And we realize that this is going to be a struggle in some offices, because you're going to maybe have to change your paradigm of how patients come in. But it is critical to picking up both of these diagnoses and starting treatment earlier. And then based upon the population data that we now have here, I think we can refine our normal range. I will conclude there and turn it back over to Fadi.
So I know Andy had some slides at the end to wrap up the presentation and to make the plea to you. So as we heard, hopefully we answered why the second newborn screen is important. We talked about the financial benefits, how much cost we save by proceeding to the second screen and not proceeding with evaluation and testing after the first positive screen. We would have a lot more false positives. And not to mention the second point, the saturation of resources. I don't think our sweat chloride lab can handle sweating 1,000 patients a year compared to what we do now with much less than that. I don't think our clinic can handle all these false positives, and also not to minimize the anxiety and the stress we would put on families by having that phone call, you have an abnormal newborn screen, and having to go through further testing to find out later that it was nothing. And to summarize, the current mandate for the second newborn screen is 7 to 28 days. It's a very big window. And it's causing delays in interventions. And as I said earlier, we looked in 2016 at the current newborn screen process for cystic fibrosis. Back then, the DNA testing was the bottleneck, and since we addressed that, when we looked at the numbers again, the second newborn screen now has become the bottleneck. This compares Utah to the other 2 screen states. And as you can see, we have the biggest window and the latest age for the second newborn screen. you have a state like Arizona, 5 to 10 days expectation for the second newborn screen, and then you have the other extreme, Utah, 7 to 28 days. But how do we actually do? This slide is for Utah age distribution for the second newborn screen. As you can see, the median is 14 days. But clearly there are some cases that are all the way even more than 28 days, and those are the ones we're trying to avoid and have everyone done in this window. And I think what we can see from this slide, it's doable, and we're already doing it in most of the cases, but we just want to make it an exception to avoid those outliers on the other end. And this slide is just to rephrase the same thing. This is the current process. We have a big window for the second newborn screen that pushes the diagnosis and treatment further away. And the goal is to reduce that window and capture them sooner for diagnosis and treatment, which will improve outcomes in the 2 examples we had today, but also applies to other disorders out of the 40 disorders that we screen for. So in summary, we want to improve the time to diagnosis. We have already improved the DNA time to diagnosis, and sounds like there are some improvements with TSH for congenital hypothyroidism. There has not been any limitations with the clinical programs, so once the newborn screen is done, they're able to get in clinic and receive care quickly. So, like I said, the next bottleneck is the timeliness of the second screen collection. The action we're suggesting is to decrease the age for the second newborn screen to 7 to 16 days. This will need support from everyone who's here, everyone who's watching from home. And once this is done, we also have to make a good job of educating everyone that the limitations or the definitions has changed. We need to get kids into the offices sooner to get the second newborn screen. We're counting on everyone who's here. And also we want everyone's feedback. This is a lot to process. Kim's email is here, and you have it in your handouts. And I agree with Mary. I want to acknowledge the newborn screen program. Andy, Kim, and David has done an amazing job. We have seen significant improvements in the cystic fibrosis side. Sounds like it's also seen in the congenital hypothyroidism world. And we'll open up for discussion if you have any questions. Mary, you're welcome to join me.
Mary, you mentioned an abstract that reported that even with newborn screening, congenital hypothyroidism is being missed in half of the afflicted cases. Does that reflect people out of hospital births or refusing testing, or are there some other factors that might cause changes in the program or clinician behavior?
I think that abstract which started all of this was a collection. The question was, do I need to repeat the question? Okay. The abstract that started a lot of this investigation from the side of congenital hypothyroidism was a very, very poor analysis of data. When we have reviewed that data, the rate of missed cases is substantially lower. It's closer to Zoe Raleigh from our group has been doing a lot of this work. It's about 13 or 14%, right? Yeah. So that abstract started the investigation, but we have not substantiated that conclusion. But it has uncovered some things that we think we can address with the newborn screening program overall that will improve our diagnosis and treatment.
A question regarding cystic fibrosis. In the not too distant past, there were a fair number of kids with CF who did not have classic DNA genotypes where the sweat testing was critically important. The knowledge about genotypes has probably improved considerably. What percentage of the kids who are diagnosed now have genotypes that that they're still detected by sweat testing rather than confirmatory DNA?
So newborn screen is just a screen process. So just to make a point that if you ever see a patient that it could possibly see cystic fibrosis, even if they have a negative newborn screen, you should do a sweat chloride test. So, but for us, the patients we see, to get the sweat chloride test, they would have had to be positive with the newborn screen. That's how they get to the sweat chloride test. All of them get the DNA testing if their first two screens are positive. If they have 0 mutations, they don't get the sweat chloride test. The mutations we test for 60 mutations, and they are based on what we see in Utah are some of the most common ones. But that being said, if the patient has symptoms, then we might sweat them regardless of the mutations. If they're losing weight or not gaining weight, or they have GI symptoms, we will still see them and evaluate them. But just the screen without symptoms, if you don't have any of the 60 mutations we test for, it's called a negative newborn screen, a normal newborn screen.
If they have one, they'll still sweat. Borderline or further. We do send out further mutations to look for the more rare that aren't captured in the newborn screen panel.
And cystic fibrosis is really a spectrum. It's not just yes or no. And there is CFTR-related metabolic syndrome. Those patients could have only one mutation, or one mutation that's known to cause cystic fibrosis and a second mutation that's not known. We don't know the significance, and those might have borderline sweat chloride. So it's really muddy when you get in the details of DNA testing. But sweat chloride remains the gold standard way to diagnose patients.
Understanding that the conditions you're talking about are some of the more common ones to be identified in newborn screening, does this problem apply to all of the newborn screens being done, I assume, since they're done at the same time? What have you identified as the barriers to getting to second screens done?
So from my understanding, and I'm not someone who deals with it directly, sometimes it's hard to get the patients back to the primary care office to collect the second newborn screen. And there are other delays where the way they mail it back, it's not the fastest way. In the past, it used to be that the state lab is not open all days, but that has been taken care of. They're open 7 days a week now. I'm not sure if Mary, you have anything to add.
The only other thing to add is sample collection. So a little safety story of ours. Several years ago, a kid was diagnosed with congenital adrenal hyperplasia, was started on treatment. Things were just not the way we expected them to be, so we did a reevaluation, determined that he did not in fact have CAH, had to wean him off his steroids, and it turned out that the sample was collected incorrectly. Cord blood is not an appropriate sample for a newborn screen. And this, I mean, it took quite a while to track this down. But some of it is improper sample collection. Some of it is delays in getting the sample to the lab. I think the thing that, as we started talking about this in the newborn screening group, one of the concerns that came up was how to get the kids back to their pediatrician's office or family doctor's office at between 7 and 14 days. And it was felt that that could be really hard to do. And that's part of what we're trying to do, is find out what are the barriers at the office level to doing this, and are there things that we could do to help with that, and also, or the state screen could do, I can't do anything, but is there anything the state can do to help with that? And also to convince you that in one of the first tests that was ever started to one of the more recent ones, this time window is critical, because the point of this is to get early diagnosis and start treatment. So we're proposing this and asking for what the barriers are, and are these things that can be fixed at the level of the primary care office?
And one thing I want to add is Actually, this large window is a barrier because when you're giving the impression to the primary care physician that you have anywhere up to 28 days to collect the second screen, even when they get that letter or that call that the first newborn screen was abnormal, there's no urgency. I have 28 days to do it. So I think it's a barrier by itself. And cystic fibrosis care is evolving and advancing, and we have so many new treatments. But the truth is that you're as good as you are when you start the treatments. And as I said, some of these growth deficits are irreversible. So if we have a new therapy that you can start at 2 years of age, but you're already stunted or you have compromised nutrition, the new therapies are not magic. They're not going to go back and reverse everything that already happened. So it's important for cystic fibrosis and many other diseases. And it really does come to the point where every day counts.
So is there a biologic reason to wait till 7 days for the second screen? We see kids now, or used to see kids, would be sent home 24 hours. They had their first screen, they come back at 3. Why not do it then? Or if they show up day 5 for bilirubin check or some other reason, that checking them at 4 days or 5 days for the second won't work?
I can tell you not from a cystic fibrosis standpoint because some states do only one screen, but my understanding is for other diseases, you cannot repeat the test before 7 days of life because it would not be accurate. And I cannot really tell you which diseases, but maybe Mary can.
For congenital hypothyroidism, if you do it before 5 days, your target could be different than if you're doing it at 7 to 10 days. Your TSH, because of the normal physiologic response. So it could potentially distort the normal range or the cutoff points. So getting out to 5 days plus, 7 days plus is going to give you a better, a tighter window on the normal range. I don't know about other conditions.
My memory is fuzzy from when I had my 2-week-old 13 years ago, but I felt like there was a 2-week check. Is that right? Okay, I thought. I'm like, I forget most of those weeks.
My question is about the mandate. So does the state have the resources to issue a fine or whatever? I don't know what the penalty is if you don't conform to the mandate, and who gets penalized? Is it the parent? Is it the provider? Is it the caseworker? Is it like who? And how do you turn it into a positive experience? Because when I had my newborn and 2-week-old, which wasn't as long ago as Joyce, I don't actually remember anyone doing good education on the importance of the newborn screen. But I do hear a lot of parents tell me how awful it is to have their kids' heels pricked.
You're just tough, Joyce.
No memory.
I don't think we know the answer, and Kim is here, so you can email her for that. But I know for the first newborn screen that hospitals keep track of that. That's reported to the hospitals, and they want to stay within the 24 to 40 hours for the first newborn screen. But I don't know for the second newborn screen.
Actually not a mandate, it's a law. It's in the statute.
Yeah.
And the only exception a parent can, religious exemption. And as far as I know, there are no religious say you can't get a. We again to attend in the nursery. That would come up from. I don't know what the penalty. Parent absolutely. But it's against the law to use a newborn screen.
Call Tony.
Call CPS.
To address Nikki's question a little bit, I think that newborn or parents of newborns are, in a state of disarray, and there's so much that they need to learn during that very short period of time that unless somebody has really emphasized the importance of this well before birth, the likelihood that they're going to pay much attention or remember much is low. I mean, not for any fault of their own. So I think that some intervention prior to birth, like in an OB's office, might make a difference. That's a testable question. But I think the other key is, indeed, how do we get these kids back into primary care settings in an urgent way? And if you add up all the numbers and look at the size of a pediatric patient panel, the average pediatrician will have 1 to 3 of these in a career. So setting up systems in practices to deal with rare events is a challenge. But absent a system, it won't be done well. So I think that having systems that can support doing the right thing every time safely is important.
I wanted to add a plug to the second screen. In the metabolic clinic, we take care of the majority of the 40 conditions that we have not talked about. And we have been... Well, it's we've been actually picking up several cases on the second newborn screening that we did not on the first, and the charts look a little bit like the ones that you showed for congenital hypothyroidism, with the first screen being well under the cutoff and the second being above. So there are, I think, additional benefits to the second screen beyond the ones that you have very well discussed here. The second comment is, and I think you have alluded to in some of your charts, it seems to me that by the data you showed that tracking things according to the average day is not a good way of looking at the data, because the distribution seems to be fairly skewed. So I think it's a very good way, the way you showed it, looking at both the median or the fraction of cases that would not be captured one way or the other. So I hope that your input perhaps will change how things are reported nationally, because I don't think they describe well what's going on. And the question I had, especially for congenital hypothyroidism, is what is the biologic basis for most of the cases? Is it essentially a congenital malformation, a thyroid gland has not developed, or is there some other thing that we can do in order to prevent that?
About 70 to 80% are congenital malformation and sporadic. So there are some inherited conditions, but most of those the family already knows, so it's not going to help you a lot. Most of these are sporadic and unknown. My question back to you is, my understanding from the newborn screening program is that 7 to 14 days would fit perfectly well with the metabolic conditions also. It would not be a problem to shorten that window for you guys either.
Yes, it would not. I mean, with metabolic conditions, there's the fact that sometimes it takes some time for the child or for the baby to have the biochemical abnormalities show up, because, of course, moms have a lot of stuff. And so I don't think we'll ever get away from needing sort of a second screen. Then the timing of that could be worked on.
Well, I think we'll need to wrap up. Prick those heels early and often, and appreciate your presentation and your pinch hitting. Email Kim if you have questions.